Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast series is to bring you short, educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment in the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job of caring for people living with dementia and connecting them and their care partners to the things they need. Welcome, everyone, to today's Dementia Care Aware podcast. I'm very excited to go over the topic with our speaker from the March webinar, Understanding the New Diagnosis and Treatments in Alzheimer's Disease. I'm Anna Chodos. I'm the Executive Director of Dementia Care Aware. Very excited to welcome back Dr. Ren van der Vrede, who's one of our assistant professors of medicine in the Department of Neurology here at UCSF, and who, again, I'll refer everybody back to the wonderful webinar we did, but today we're really going to get a chance to talk about this information again. So welcome.
Well, thanks so much for the invitation. You did a great job with my name, by the way.
Thank you so much. So I will start just, getting us all to level set again on what we understand about Alzheimer's disease. So in Dementia Care Aware, as I think we talked a little bit about during the webinar, we really focus on this broader clinical concept of dementia as a clinical syndrome. And we say things like Alzheimer's disease and related dementias. But your webinar really helps us understand more about how we're understanding the pathophysiology of Alzheimer's disease and now how that's leading us to these new diagnostics and treatments. So would you please be able to start there again and go over what is it that Alzheimer's disease is and what we should know?
Yeah, of course. Yeah, it's always good to start at the beginning, I think. And with Alzheimer's disease, if you start at the beginning, it's with Dr. Alzheimer's and the first report of the first patient in 1906. And from the beginning, it was what's called a clinicopathologic diagnosis, right? So he observed the clinical symptoms of the young woman, likely with a pathologic mutation that ran in her family, a presenilin gene. But she had progressive problems with her memory that eventually ended up taking her life. And he used what was cutting-edge technology at the time to find out what the cause of it was, what the pathologic cause of it was. And it was the plaques and tangles that we now know lead to the clinical symptoms that they saw. And he used the Bilkowski silver stain and Congo red, which was, again, that the best available that he had to be able to relate that as the cause of the symptoms. And then it became understood generally that the symptoms, these changes, progressive cognitive impairment, and especially in older people, was a disease, and that disease was found to be very common. There's a landmark paper published in 1976 by Katzman that said Alzheimer's disease is a major killer, that it isn't just inevitable that your memory gets worse as you get older, this idea of senility. It's just that Alzheimer's disease was so common, it was thought to be inevitable. But we knew that people that get older don't necessarily have worsening of their memory symptoms. And so the concept of dementia was just the clinical symptoms, because that's what we could identify in patients, was the worsening memory or the trouble with language or the trouble with navigation or with relating to people. And when that is severe enough to impact your day-to-day function, we call that dementia. And we came to realize that there were earlier stages of that, which we call mild cognitive impairment, where you have the symptoms, but maybe it's not yet impacting your day-to-day life. And there's even earlier stages than that we found of the disease. And the most common disease that causes dementia is Alzheimer's disease. But from its conception, from the initial conceptualization of it, it was the plaques and tangles. It was the protein buildup at the brain. We just had no way to detect that until somebody passed away at autopsy. And so the clinical definition for years and years, almost 100 years, really was, for all intents and purposes, the disease, because we couldn't relate it back to that pathology. But now, because of all the new tools that we have, the multiple modalities of testing for the proteins, we are able to give that precision diagnosis even during life, even in the hands sometimes of the primary care physicians. You've had sort of a reclamation of that clinicopathologic diagnosis, which is the most precise description of what's going on, the degree of impairment, what's impaired, and what the cause of it is. That's probably the most specific you can get for a patient.
interesting, but I would say also provocative description, because I think a lot of us still really are practically operating in this realm of really the clinical symptoms leading us to a diagnosis, and then doing the best we can to get this sort of pathological understanding, either based on pattern of symptoms or other information we have in a scan, more just like a structural scan with an MRI or something. But the path you were leading us down made me think, okay, so would you say now we can get a accurate biological diagnosis and find evidence of the pathophysiology, prior to autopsy?
Yeah, you can do that for Alzheimer's disease because we have new PET tests, we have CSF tests, and we have the new blood test. So you can get that precision diagnosis. And the clinical syndrome alone is good but not great. We found that it's accurate in about 85% of cases of dementia, even at the best centers, that's you and me, being able to identify patients we think have Alzheimer's disease. If you follow them to autopsy, we're right about 85% of the time. The 15% are usually related disorders that are also neurodegenerative. And so when it comes down, if you don't have treatments that target those pathologies, for all intents and purposes, it doesn't really matter if it's these other neurodegenerative diseases because the course may be slightly different, the cause may be slightly different. But if it really is neurodegenerative, it's still a relentlessly progressive syndrome that involves cognitive impairment that impairs function, eventually leads to death. But in the era where you do have targeted treatments, where the precision diagnosis is necessary to qualify for those treatments, then having that understanding of what the pathophysiology is becomes all that more important, which I think is why you're seeing this rise of biomarkers and the need for precision diagnosis going hand in hand with the treatments that are becoming available.
Okay, Ren, so walk us through what the biological diagnosis would look like and what are the tools we now have to get there?
So for a biologic diagnosis, you need confirmation of the neuropathology. And for Alzheimer's disease, this is the plaques and the tangles, the amyloid plaques and the tau tangles. So to have a precision diagnosis that involves the biologic component, you need a test that looks for that neuropathology. We have PET scans, we have CSF tests, we have blood scans, and they're all basically designed to target changes in amyloid and changes in tau that are suggestive of that neuropathology building up in the brain. That's what you're getting with the confirmation that that process, which we call Alzheimer's disease, the plaques and tangles, is happening in the brain and likely to be responsible for the clinical symptoms, dementia syndrome, that you see when you evaluate the patient.
I'm going to infer from that we're not using this to diagnose the biological process of Alzheimer's disease in someone without symptoms, but we're using it to confirm in somebody with symptoms.
100%. Yeah. The appropriate use recommendations for all of the biomarkers are for their use in symptomatic patients because you're looking for an explanation of what the cognitive symptoms are caused by, often to have an understanding of what the clinical course will be, to allow them to do advanced preparation, all the things that we think about and have thought about for the last 100 years of caring for patients with this disease, but then also potentially to qualify people for clinical trials or the new disease-modifying treatments.
Let's do a little deeper dive into what the tests are. So you said the PET scan, PET biomarker scan, the blood-based biomarkers, and then CSF tests as well.
So the CSF tests we've had for the longest time, those probably have been in existence for about 20 years. CSF testings require lumbar puncture, or what's called a spinal tap, to collect the cerebrospinal fluid. And then you can test for the abnormalities in the amyloid or the tau protein that suggests that Alzheimer's disease is present. We're also able to use imaging. So we have an amyloid PET scan. This is where you infuse a radio tracer. It binds to the amyloid protein in the brain, and you detect it with the scanner, and it lights up the amyloid protein if it's present in the cortex. And you can see it when you look at the image. You can even quantify it. There's scales to quantify it. And we have a radio tracer that works for tau now as well. So you can infuse that in the same way as amyloid, and you can get a tau PET scan and see the tau light up. And we know that the meaning of that's a little bit different, that amyloid PET and the CSF testing actually does turn abnormal even before there's clinical symptoms. It can take a positive even 10, 12 years before their symptoms. But tau PET seems to turn positive about the time that the clinical symptoms are accumulating. People say maybe this is amyloid is like kindling, and then something called a catastrophe happens, and then the tau actually starts spreading along networks. And then the real revolution, the one I think gets really exciting, at least to me, was in the last sort of 3 to 5 years, where we had improved technology to be able to detect those same proteins as in cerebral spinal fluid, but now we could detect them at the lower concentrations where they're found in blood. But fundamentally, it's sort of the same test. They're often discovered in cerebral spinal fluid and then adapted to be detected in blood. So that same test that used to require a lumbar puncture now can be done with just a phlebotomy. And that's become available over the last really year and a half in clinical use and has made it easier than ever before to get the diagnosis. What used to be, I think this is humbling in some ways, what used to be in the purview of a neuropathologist and required autopsy could now be done even by a primary care physician at the first visit when you find a patient has cognitive symptoms that you think are suggestive of Alzheimer's disease. But then, with that, the increased power of that tool, then making sure it's being used appropriately, I think, is of increasing importance because of the stigma associated with Alzheimer's disease and what that diagnosis really means when you give it to people. Just because it's easy to diagnose, you have to be even more certain about that diagnosis when you give it.
So how accessible are these tools?
Yeah, it's a good question. The answer is, in some ways, they're very accessible because they're available by companies that are out there that you can write a requisition form and send somebody to a lab facility and they could get the test performed. There was even, for a brief period, direct-to-consumer tests that were available where patients could order this online and get an answer. Fortunately, those were pulled from the market. That's been discontinued. There aren't any direct-to-consumer tests that I'm aware of, but any physician could order the test for the patient. Where I've really seen them being used is by people that have competence in using them. This is often in subspecialty settings. In our clinic, in the Memory and Aging Center, we introduced them for the first time was July 2023, so it's been almost 2 years of use. And in the first year, they were ordered about 200 times, often for the purposes of identifying Alzheimer's disease is the most common use reason for the biomarker test. But increasingly, I'm seeing patients being referred to me where these tests have actually been performed by outside clinicians, either neurologists or even, in some cases, primary care physicians. But at least one case I'm thinking of that occurred, they were referred to me without a clear understanding of what the tests said and had been sitting uncomfortably with that information for a couple of months before they got into me. And I was able to say, oh, I know that test, that one's not very good. This test is very good. Let's go and get the gold standard test to make sure that we have the highest certainty possible about this diagnosis. And so in some cases, that's where I worry, is that the tests are sort of set without an understanding of what they mean or how to interpret them.
Yeah, and without endorsing a product, you just sort of alluded to the fact that there's some out there that just aren't as helpful clinically. And I think I know one of the challenges that sort of I feel like I face, which is what would I order to, we're not offering it where I practice, but is there one that you would recommend or a way to navigate that?
Yeah, I think it's a challenge. It's a challenge for me, and this is my world. This is what I think about to keep up with this space. I just was at a conference and did a presentation, was with a colleague, and they had a slide that was from earlier this year, and I said, that slide's actually out of date already. And so trying to keep up with all the changes in this fast-moving field, I think is impossible, just to say it in a few words, especially because we're in this space where these tests can become available without full FDA approval. And that's a blessing and a curse in some ways. Our European colleagues don't have that. So there is no accessibility for blood biomarkers there. But we do have the availability to order lab developed tests here in the United States. But that puts the onus on the physician to be kind of a savvy consumer of the tests. And so I think, knowing about the test that you're going to order is the most important one. We wrote a guidance about clinical implementation. It's out there on the literature. And I think I said in it, Suzanne Schindler and I said, the best biomarker test is the one you can get and the one that you have confidence interpreting. Right. And so I would hazard to, as you said, recommend a single test, but I think it's going to be in not too short order that will have FDA approval for test, which is always helpful in understanding what the diagnostic performances and the level of certification of it. We'll have coverage determinations to know that it's not going to give patients a bill at the end of the day for something that's not covered by their insurance. And we'll have a lot of real world use coming from centers like ours about how it performs in our hands and in the hands of a primary care physician. So it may be that it is a little too early to think about using these tests, but if you are somebody that wants to be on the edge of that technology, there's lots of guidance out there for sort of picking the right test that's available. But I would say just know the diagnostic performance, know the limitations of the test, know how much it's going to cost your patient, if any, and then know what you're going to do with the results, right? And part of that is incumbent on people like me and you to go out there and teach people about these tests and how to use them. But we're still learning in our hands, right? We've been using them for less than 2 years.
That's super helpful context because, and I also think a lot of people are going to have patients that, as you pointed out, just come with some results and you're trying to make sense of it and really may need to defer to somebody who's using or seeing more of these tests because they're just not quite easy interpretation and it's still early days. So that is really helpful. Can you say a little bit more too about the amyloid PET scans? Like an example, I had a friend of a friend who had one and was really alarmed that it seemed like the readout was just, positive for, finding of amyloid protein or something. And, to her, that was a super inadequate report in a head scan or a brain scan. So I tried to explain to her, like, it's not structural. It's not going to give you a lot more information. They're really looking for the yes or no presence of amyloid. And that was the best I could do at that moment. But yeah, what should we be expecting? And my understanding is a lot of the times these are done in centers that, have a lot of experience and they have an understanding of how their scans are performing and things like that. So if, let's say we get a patient who's had one, or now we find out that a local center is ordering them or we can order them, how should we be thinking about those tests?
Yeah, this is another challenge that we have. There's a change recently because previously there was a non-coverage determination for amyloid PET. It wasn't covered by Medicare, so it really wasn't used, even though it's been in existence for over a decade. And it's been used in clinical trials and in research settings. So most of our understanding about its use comes from those instances. Really, its clinical use or clinical utility, that's only been studied more recently by like Gil Rabinovich and others. But we did have a reversal of their non-coverage determination that is available. So Medicare will pay for it for the diagnosis of Alzheimer's disease. But there are nuances in that interpretation. As you said, there's 3 FDA-approved radio tracers. To be able to read them, it's usually nuclear medicine. It requires training to become an expert reader. But when you do, you look at it. The white matter also shows the signals. There's off-target binding to the white matter. So you see a lot of sort of dark signal from like the brain skeleton. But then the cortex or the gray matter is where the amyloid accumulates, and that will become positive. And so I think it's hard to describe the picture, but it's like a tree without leaves or a tree with leaves, basically, is the positive scan because that differentiation between the gray and the white is obscured. And having looked at now a couple of hundred of these scans, I would say it is a little bit of art as well as science. And we have a policy of overreading every scan that's done in the community because we've found that the accuracy is dependent upon the quality of the rater as well as the scanner. And we've overturned some results that were read outside when we have our folks here that because they've been reading them in research world and clinical trial, read thousands and thousands of scans. We've actually overturned that. And the interpretation of any biomarker can't be made without thinking of the clinical context of the patient. Like I said, biomarkers don't wear stethoscopes and give diagnoses. That's what doctors do, right? That's what clinicians do. And so you have to interpret that in the clinical context. With an amyloid PET scan, for instance, I know there are things that can impact that. It can turn positive even before there's disease present, 10 to 12 years even before the disease. So again, in an asymptomatic patient, you might have a positive PET scan. What does that mean? That's really hard to determine. So I say don't scan people that are asymptomatic. But the interpretation of it has to be done in the clinical context, and there's nuances to it. a lot of nuances to it. So I think probably the CSF tests and the PET scans, especially like the tau PET, which is quite expensive, amyloid PET again is quite expensive as well, though now covered by insurance, that probably will be done in expert settings, I think, more often than not. And you'll be using the blood test more frequently, maybe as gateways or triage to some of the more expensive or invasive ways that you would test for Alzheimer's disease. But any new tool, never know how people are going to use it. I say sometimes, you leave a hammer in the center of a room, somebody might use it not to pound in a nail, but pound in a screw. And you say, I never would have thought of that it would be used that way. So a lot of it is about making sure that you can interpret it appropriately.
That was so helpful. I did not realize that there was that much variation in the way to read those scans. And definitely, I had done a visit to Georgia where they have a great statewide network of specialty clinics to make sure and like really close ties with primary care. So they get people, in to get assessed and get a diagnosis if they can. And they have these like very experienced centers that can use the scans. But that is really helpful and wonderful context as we're thinking about, like, if I get a read from, if a patient shows up and they went somewhere, to just really put it in context and maybe not just jump to the positive finding. That's so helpful. Also, if I found a hammer in the middle of the room, I would probably end up using it to eat my lunch because I always forget a fork. I'm always trying to find creative ways to eat my lunch, and I always bring a lunch that I need a utensil. So, okay, I think we have a really good understanding of how we are now at a point where we can get information about biological processes in the brain that are prior to the patients dying from the disease, that we're using these biomarkers in clinical context and always with patients who were already in the process of doing a clinical workup for symptoms related to dementia. Your prediction, and makes a lot of sense to me, that much more widely used, we're going to see the blood-based biomarkers at some point, and that these PET biomarker scans and CSF will continue to be more prominent in highly specialized centers. So I'm just doing a little bit of recap to make sure I'm following. And so now we have someone who, like you said, we've improved our accuracy of understanding what's going on with them. They're having symptoms. They have evidence of amyloid or tau pathology. What now is the reality or the emerging reality around treatment and disease modification?
Yeah, it is a revolution. It's an inflection point, I think, because to state it plainly, it's the first time we've been able to modify the course of the disease. I mean, I say that sort of blithely, thou disease modifying, but all of our treatments have been symptomatic up until this point. They've given you a little bit of a boost cognitively that hopefully that would delay the time that you needed additional help or placement at facility. But now what we have is targeted therapies that go after one of the neuropathologies in Alzheimer's disease, the amyloid plaques. And these are the disease-modifying treatments. Lecanemab and donanemab are the two that are now FDA approved. And what they are is they use antibodies, which are your body uses to fight infection, but they're designed to identify and clear the harmful deposits of amyloid plaque that are in the brains of people with Alzheimer's disease that we can confirm with these tests. And we knew, because we used the PET scans to demonstrate that we could clear these plaques from the brain. That was known 15, 20 years ago, that the drugs would do that. They would take a positive PET scan, so to speak, and turn it negative by removing the plaques from the brain. But what was shown in the two large phase 3 clinical trials was that mattered, that it did slow the disease down by about 25%, which doesn't sound like a lot, but it could be the difference of over 18 months, maybe additional 4 or 5 months of time in the early stages that we say. And that really is changing the trajectory and the course of the disease and changing the slope of progression over the entire disease. Hopefully, maybe could buy you an additional year or two. And I would argue that is clinically meaningful for patients. But there are limitations to this medicine. One, it doesn't cure. It doesn't stop. You still see progression in patients. And, I sometimes use the analogy of like a car. If you're driving in a car going 60 miles an hour to a place you don't want to go, which is the next stage of the disease, be that dementia, or if you're an MCI, it would be dementia. If you're dementia, maybe a more moderate or severe stage of dementia. I can slow that car down to 45 miles an hour. If you don't have a speedometer, are you going to be able to tell that you're going 60 and you're going 45? You might not, but that time difference that it's going to take for you to get to the next generation, you might notice that. So that's what the drugs do. Um, they only seem to work in patients in the earliest stages. They're for symptomatic patients only, just to say that clearly, but in the earliest stages of the disease. So I think it now is increasingly incumbent upon us to identify those cognitive symptoms that are worrisome, give them that clinical diagnosis, and understand the biologic cause. Because the earlier you treat and the faster you remove the plaque, it seems like the better the response is. But this clinical benefit doesn't come without risk. By using the immune system to clear the plaques, you can overactivate the immune system, cause something called amyloid-related imaging abnormalities, or ARIA, which is a very pretty name for something that isn't very pretty. And this is changes in the brain, bleeding and swelling, to state it as succinctly as I can, that are related to that clearance of the amyloid. And you have to use relatively careful patient selection to identify patients that don't have a high risk and a high likelihood to benefit. And that's sort of what our field is engaged in right now, is being able to identify those patients that will benefit. And it's a fraction of the people with the disease. Some estimates as low as 5% of patients would qualify for these treatments. But there are also trials, I'll say. I'm an optimist and a clinical trialist, and I'm really excited about what's coming down the pipeline for Alzheimer's disease, maybe in the next 5 to 10 years, which would be another reason you would want, definitive diagnosis and biomarker confirmation. But the current generation of drugs that we have to get this benefit, even with this risk, are somewhat complicated to administer as well. They require an intravenous infusion. They require you to come in either every 2 weeks or every month to our center. You have to have very frequent monitoring. There's something like 4 MRIs within the first year, very frequent touch points with our center. And something I worry about is people becoming professional patients in a way. But I think for that benefit for patients in the early stages, if we can hold you there for longer, and we can delay your progression to those stages of the disease, what people think of when you say Alzheimer's disease is often that moderate and severe stage of the disease. I think of Alzheimer's disease as being this huge spectrum of presentation that you can have of it that can be very early, even undetectable in patients. Maybe people can hide it often early on from other people, but they think about those later stages. And if we can keep you from getting to those later stages and maybe buy you more time for the other clinical trials that we're running to maybe bring more effective drugs into the clinic, then that's really worth it. So I think, we've conceptually undergone this inflection point where we've shown that this disease is treatable. This is the first generation of drugs in this class. They're quite complicated to administer. The benefit is real, but again, not sufficient given the degree of illness that's out there. But I think for me, it's a proof of concept. And it tells me that we need to be ready for next 10 to 20 years when we're going to have lots of new treatments and combination therapies and consolidation therapies and maintenance therapies and anti-inflammatories and pro-cognitive agents and things affecting neurogenesis and gene therapy and cell therapy and all of these tools brought to bear on the disease. I think some of it is getting people ready for that, what I think is an eventuality, even though it might take us a decade or more to get there, assuming we could stay on track.
Thank you for that comprehensive and measured assessment of the new therapies. I mean, I think, we hear disease modifying, which definitely sounds less exciting than cure, but, disease modifying treatment for Alzheimer's. And it really, I think some people get very, very excited. And I agree with you. We should be excited. I think there's no question in my mind that patients, families, people's, people in people's lives who are living with dementia, people really want to change the trajectory. And it's just really interesting to hear how this is developing and how it's, adding to the arsenal for, people who are good candidates or who can go through the whole thing. What I'm hearing is, and I know in my experience, if we find somebody, and I think you pointed this out, but somebody who's, really still very mild, and then they meet criteria and we find that they have biological evidence of Alzheimer's disease specifically, and now they're a candidate and they don't have contraindications. Really at that point, I'm doing the clinical workup and then I'm referring. So I think most of us probably in the frontline primary care end of things are a little off the hook in terms of really explaining all these, all the complications and what it really looks like to be part of getting this treatment. But I think this was really, really helpful context because I think probably a lot of us are getting asked about it more and more. And, we'll hear about it on the news and things like that. So I guess the other thing I would just highlight, as you were talking, is this is really just another good reason among many, because, we know a lot of other things can modify someone's trajectory, but, just to be hopefully as early in our process of detection and addressing Alzheimer's, whenever we can. So I guess I'll just sort of end on like a little bit of a summary and bringing it back down to earth for all of our general practitioners out there. As and if we're embarking on sort of more routine and regular detection, screening of dementia and symptoms, and then we're helping people get their symptoms assessed and doing some of the workup, probably more and more we're going to be seeing the introduction of information from biomarkers, possibly something someone got in the community. And if we happen to be in a place where they can get assessed for and sort of really truly diagnosed with having Alzheimer's disease biologically, pathologically, and they're in a place where they can get the treatment, then this might be something that modifies the disease for them, buys them extra years and time with less disability and less symptoms. I know in my conversations with patients, I've often sometimes said, in a lot of ways, when people embark on this treatment, it kind of looks a little bit like what you might think a cancer treatment might look like this, you have to monitor for symptoms. There may be some serious side effects. It's going to be infusions and going to the doctor a lot. Do you think that's a fair way to describe it for patients?
I think it's exactly right. I think for me, oncology is my North Star. In some ways, it's also a source of understanding where the pitfalls are, because there's a lot of medicines used for cancer where you can't fit a laser pointer between the Kaplan-Meier curve and are quite expensive and complicated to administer as well. But I think for the last 50 years, if you're within 100 miles of an academic center, you're in a clinical trial for cancer. And I think Alzheimer's is equally devastating as a diagnosis and equally important. But there's been these two myths about it, which is futility and fatality, that, oh, it's inevitable, everybody's going to get it as they get older, which is not true. Or there's nothing we can do about it anyways, there's no need to diagnose it, which is now not true as well. And so now with the overturn of those myths, then, yeah, I think it is probably incumbent upon everybody in the medical field, and especially primary care doctors, to diagnose early. I would argue that has always been the case, that you always should be identifying and diagnosing it early for the reasons that you mentioned. And the fundamental disease hasn't changed. Everyone knows Alzheimer's disease. We've all seen it. We can recognize the clinical symptoms and the syndrome. But now we can confirm the biology, as you said, and we can route patients for treatment either through a clinical trial or to the treatment clinics, which I agree with you are probably going to be at specialty centers in the hands of specialized practitioners for the foreseeable future. If the next generation of medicines, though, work better, have fewer side effects, and are less complicated, you could actually see that moving into the primary care world. And then you have to have even more comfort with being able to identify it. But using, a blood test to confirm a diagnosis is not all that different from the typical care that you would give a patient. And if it's a good test that you have high certainty in, then there'll be a lot of confidence and usage of it. And I think we're also looking, and we didn't talk about it, but there's 2 prevention trials where they are actually trying these medicines in people that don't have clinical symptoms, but do have evidence of the disease process. And we're going to have readouts from those trials in 3 or 4 years. And if that's the case, then you have to talk about screening patients that don't have symptoms if you really can prevent them from ever getting into the symptomatic stage. And so that's sort of looming out in the horizon. And that can't be me. That can't just be even neurologists. That really has to be all of us. That's really going to change our approach to this. And I have to say, if you can prevent people from getting the symptoms, then it's worth it. We'll do whatever we need to make sure that we've got the tools necessary to identify patients and give the treatments. Because if you can prevent people from getting to that stage of memory impairment or dementia, especially the late stages, that's really what we want. That's what we're all after.
Uh-oh, another podcast, another topic. Thank you. No, that was yeah, I think we can all, I think we're all really hopeful that one day that really is a possibility, but nothing more humbling than the brain and the pathology and work in helping people with dementia. But today was wonderful, and really, really appreciate both your eloquent and clear, helpful kind of context and walk through this new terrain. So thank you so much again, Ren, for speaking with us, for helping to educate us. And sounds like a lot of updates and a lot of work to come. So we'll keep our eyes peeled and keep abreast of new developments. I just want to say thank you so much for your time today.
Oh, it's my pleasure. Thanks for the opportunity. I really appreciate it.
Thank you for listening and to our wonderful guests. And thank you to Lisa Costello, our audio editor and voice specialist. We want to make sure you know you can get CE, CME, and MOC credits by going to our website, clicking through to the podcast page, and answering a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of our Dementia Care Aware team. If you want to learn more, please visit our website, dementiacareaware.org.